Welcome to the Practicing Clinicians Exchange podcast, Getting Ahead of the Pain, Preventative Options for Migraine. I'm Karen Williams, family nurse practitioner and deputy director of a headache center, and I'm here with Maureen Moriarty, adult nurse practitioner and owner of a headache center in Maryland. Today we'll be talking about the available therapies for migraine prevention and strategies to use them in your patient's treatment plans. This program is provided by the Practicing Clinicians Exchange for 0.5 ANCC and AAPA credits. The 0.5 credits are applicable for pharmacology credit for NPs. This activity is supported by independent education funding provided by Amgen. To receive credit for this program, go to pce.is/migraine. Our learning objectives for this podcast are to assess the efficacy and safety evidence for novel therapies to prevent migraine and to formulate treatment strategies for prevention of migraine in our patients. Okay, Maureen, we do have a lot to cover with prevention. So can you start by telling me, what do you do? How do you begin prevention? Who do you decide is a good candidate for that?
Thanks for that question, Karen. So I really do this collaboratively with the patient. And so we have a conversation about what using preventive medicine or prevention means. Some of the people that I think are good candidates that I would bring this conversation up to are, say, someone who has migraine that is so severe, it interferes with their ability to carry on their activities of daily living. So maybe it's the mom that can't drive carpool because she's so sick. Maybe it's the business person who can't go to the office, or the student who can't study because they really have lost a day or even more than a day a month because of migraine. I also look at those individuals who, say, have contraindications or have failed acute therapies in the past. So they may have tried some of the acute treatments that are out there on the market, but they're just not working. So even after they take the acute medicine, the headache is still debilitating to them. They may be an individual who's gotten into medication overuse with some of the acute therapies. So to define that, for the listeners, if someone is using a triptan, an ergot, or a combination medicine, such as even an over-the-counter acetaminophen, aspirin, and caffeine tablet, or an opiate, if they're taking that more than 10 days a month, that's considered overuse. Simple analgesics, such as nonsteroidal medicines, aspirin products, or acetaminophen, 15 days a month. And then also, too, if you look at the number of headache days that an individual is experiencing, if they're having 2 days a month where pain is debilitating, you may want to consider using prevention in that case. Once you get to about 4 days a month, that's when the American Headache Society and the American Academy of Neurology really recommend that we suggest prevention for our patients. That gives you a kind of an overview of that in a nutshell. But Karen, I wanted to ask you, so if we're looking at prevention in our patients, what are some of the non-pharmacologic therapies that we can use for these individuals before we get into some of the medication management?
Right. That is a great question, and it's so important to address that. Sometimes we're a pill society, just give me a pill and get over it. But migraine can be such a chronic, lifelong issue. So looking at other ways to combat that from a non-pharmacological standpoint, there's a variety of different ways. Cognitive behavioral therapy has been approved for headache, and also using mindfulness. Some other option can be using yoga or acupuncture. Also physical therapy and chiropractic, especially if there is a neck or myofascial component to that as well, along with the aromatherapies like using peppermint oil or lavender oil. The other part of that too is looking at their comorbid issues that they may have. Do they have sleep apnea? If you diagnose that and then get that treated, you can really reduce some of that migraine risk. Also, anxiety and depression, do we need to be addressing those issues that are so common with migraine, and working with psychology or counselors or maybe some medications that can help reduce those mood disorders, but also maybe used as a preventative as well, kind of hitting two birds with one stone. Asthma, obesity, all of these things can add to the migraine component. And so looking at what those comorbid conditions are and making sure those are being treated is extremely important.
Absolutely. Could we just have a little conversation about some of the traditional medicines that are on the market right now and some of the places where you might use those in terms of comorbid conditions that our patients are having, and then we'll get into some of the more novel therapies.
Got it. Yeah. So if we're looking at somebody who has anxiety, one of the good preventative medications that has a level A evidence are the beta blockers. So propranolol,
Mhm.
metoprolol, that class of medicine. But of course, with those, you have to be careful. You don't want to use that in somebody who has asthma or possibly Raynaud's disease or diabetes. Sometimes the antiepileptics may be the appropriate medication for them. Specifically, topiramate can be helpful in somebody who has weight gain and they want to lose some weight. On the converse side of that, though, it can cause some issues with cognition or some other side effects, such as tingling of the fingers and toes that some people don't. Divalproic acid can also be used, especially in a person who has some mood issues such as rage. It may be a helpful treatment for them. However, it can cause weight gain. So we want to be careful with that. And both topiramate and divalproic acid should not be used in childbearing ages for women because it can cause some birth defects. So that is something to be very cognizant of, especially since migraine is higher in that age group for those women. Sometimes, if it's a menstrual migraine, you can use a longer acting type of triptan to help keep them from having those menstrual migraines. You would dose it a day or two before. Provitriptan is the one that is most often used for that because it has that longer half life of 26 hours. Or naratriptan, that is the other one that is recommended for menstrual migraine. And then we can also look at, of course, on botulinum toxin A, which is a wonderful treatment for reducing the number of migraines and also the severity. That is 31 injections around the muscles of the head and the shoulders to help reduce the migraines. And it's done every 12 weeks. So it can also give you an extension of reducing those migraines without having to take a daily medication for the portion of the population that find that helpful. In addition, there are maybe some other ones that have level B evidence behind them. So looking at the TCAs, such as amitriptyline, if they have a history of insomnia or depression, that may be a better choice for them. Some other choices may be venlafaxine, and that's also level B evidence. And then magnesium and vitamin B2 can be helpful, especially in our women that have menstrual migraine, or magnesium by itself, which acts as a very mild muscle relaxant. So it can be very helpful.
Thank you. That's a really great overview. So I want to move on to some of the novel therapies that we have on the market. And so we have a couple of new classes that have come out. So we have the anti-CGRP monoclonal antibodies, and in that class are eptinizumab, erinyumab, fremanezumab, and galcanezumab. And then we also have the CGRP receptor antagonist, atogepant and rimegepant. So could you speak to those a little bit? Talk to me about the efficacy profile, who you would use these in, and actually the way that these new medicines work.
Yes, these have been a wonderful addition to migraine therapy. So the anti-CGRP monoclonal antibodies are either an injection or they're IV. They are a large molecule that blocks the CGRP, the calcitonin gene-related peptides release from the trigeminal vascular pathway. And because they block that release, they reduce the vasodilatation that the CGRP molecule causes, which leads to inflammation. So they are a nice once a month treatment or up to every 3 months, depending on which one you are using. This is a wonderful medication to use in patients who don't want to take a pill, or the first line antiepileptics or beta blockers are not something that's recommended for them, or they do not tolerate them. Often insurance companies do recommend or require that you try the other medications first before you get to this class. But it can be an extremely helpful class, and it's one that I use quite often. In fact, you can use the CGRP monoclonal antibodies along with onabotulinum toxin. And so you get the best of both worlds of blocking multiple different pathways for the migraines. When it comes to the CGRP receptor antagonists, these are tablets. And they are small molecules, so you do have to make sure that they aren't interfering with other medicines going through the metabolized in the liver, the CYP3A4, either inducers or inhibitors. But they can be taken every day to every other day, and they can be another great way to help prevent the migraines. What we're looking for is about a 50% reduction in migraine or a reduction in the severity of the migraine. And the other part to consider with this, we can't say it enough, is medication overuse. As soon as that patient starts to have medication overuse, we need to look at a preventative to help reduce their wanting to take that medicine more frequently.
Can you talk to me a little bit about some of the possible side effects that come along with monoclonal antibodies?
While they don't have a lot of side effects, there are a couple of them that we do need to watch for. Irenimab does have some issues with constipation, and it may have some issues with elevated blood pressure. So they do recommend you take a blood pressure reading anywhere about 2 to 4 weeks after you start them on that. Other than that, they are very, very well tolerated. And the same for atogepant and rimegepant. Rimegepant may cause a little bit of nausea, may also cause a little bit of sleepiness, but it is very well tolerated. And with this class, we don't have to worry about any vasoconstriction. So you don't have to worry about in the cardiac patient or the patient that has peripheral vascular disease, you do not have to worry about that this medication will cause them more harm.
Can you talk a little bit about, just for our listeners, how you store these medicines, the injectable medicines, anything to think about with those?
For the sub-Q injections, you do need to keep them in the refrigerator. Taking
Mm-hmm.
them out about a half hour to an hour before so that they're not too uncomfortable when they are injected is important. I've had several patients tell me, "Oh man, that really hurt when I gave it to myself." And it is a self-injector, so they can give it to themselves in their thigh or in their upper arm, or have a family member if they are uncomfortable with giving it to themselves. But taking it out of the refrigerator beforehand makes it more comfortable.
These medicines, they have a pretty long half-life overall. So about 28 to maybe 32, 33 days or so if you look at them across as a class. So what's your experience been in terms of getting to, say, a good therapeutic level and finding if they're really going to reduce the number of migraine days per month? How long do you typically leave someone on one of these before you might switch to another in the class?
Yeah, that's a great question. So I usually try to encourage them for at least 2 to 3 months to get that medication into their system and to start working. Up to
Hmm.
6 months may be needed. And in the case of arenimab, you can start at a 70 milligram dose and then go up to 140 milligrams. I will back that
Hmm.
back down if they start having constipation. And then your choice is to either switch to possibly one of the other medications if their constipation is a true issue. If it's not horrible, you could add maybe a stool softener on. I add magnesium because it can really help reduce that and also help reduce the migraines as well. Do you have any other tips on that, Maureen?
Well, no, I do exactly what you do. I typically will leave somebody on for at least 4 to 6 months, and I have them calendar their headaches just to see if there's any change in headache frequency over that time frame. There's just a few different little things about a couple of the medicines with fremanizumab that can be dosed quarterly if the patient so chooses. It does require that they take 3 injections with that quarterly dose, but some people like that, and they don't like, then they don't have to give themselves a shot every month. With galcanezumab, you do have to do a loading dose with that one, so you're taking 2 injections that first go round. But with arenimab, you have the option of starting at a lower dose at 70 milligrams and then upping that to 140 if you're not getting the response that you like. So I think that it gives people choice across the board. And what's your experience in terms of people using, say, the monoclonals as opposed to some of the more traditional type of preventive medicines that we've used to treat migraine?
What I have seen is that a large portion of them do very well with that. They
Hmm.
don't have to worry
Hmm.
about taking a medicine every day. There's much less side effect from that. And so it can be something that seems to be extremely helpful. You do have to, again, use some of the other oral medications first, often before the insurance company will approve the use of these medicines. But in the long run, these medicines, I think, are here to stay. And they have shown that they don't cause medication overuse. And so there's a wide variety of patients that can benefit from them.
And I think if you look at the metabolic pathway that these medicines go through, because they are large molecules, they're metabolized really at that cellular level. And so there's really no drug interactions with them if we're looking at the injectable monoclonals. So can you just comment about the new oral preventive medicines, atogepant and rimegepant, just in terms of potential medication interactions with those? Just one more time. I know you mentioned it before.
Sure.
But
So because they are a small molecule, they are metabolized by the liver. So you do want to make sure that if they're taking any other medications that pass through the CYP3A4 pathway, either inducers or inhibitors, you do have to dose those medications differently. And the package inserts do tell you how to reduce the dosing of those so that you are not interfering with the other medication.
and side effect wise with those?
The rimegepant can cause some nausea, though I don't see that too often. I do see a little bit of sleepiness with that. The other thing
Hmm.
with rimegepant is an oral dissolving tablet, so they don't need to take it with water. Atogepant does have several different dosings for that as well, so you can modify that as
Yeah, I
far
think
as
that's
what their
kind of a
dosing
nice
is.
option. There's 3 different doses that are on the market. And so depending on other medications that the patient may be taking, you have that choice. And again, in the package insert, it's going to tell you exactly how to alter that dose,
Right.
depending on
Always
what they're
checking
taking.
that
Yeah,
insert.
yeah, it's good. And then the rimegepant is an every other day dose as opposed to daily. So if people are adverse to taking a pill every day, then they have that option to use that particular
Right.
product.
The other
Yeah,
nice thing
yeah.
about some of these oral solutions is if they are a menstrual migraine patient, they might just want to take these for the few days as that prevention. So it gives
Mhm.
us yet another option for the menstrual migraine. They don't have to take it all month long if they don't need to, which makes that wonderful. Unfortunately, these have not been tried in pregnancy, so they are not recommended in pregnancy or with breastfeeding. We do not know if they pass through the breast milk either. So, as for the injectables, they cannot be used either in pregnancy.
Right, right. And again, these are all for use in adults.
Yes, 18 and
Yeah.
above.
I was just going to ask you about zavegepant, which is up and coming, still being studied, but that's emerging, if you will, on the market. But it's going to give us another option because it's a nasal spray. So it's a little different, not oral, not injectable, but nasal. So we'll have to see that when it comes to market.
Definitely. Yes. Thanks for bringing that one up.
Just something to look for. I think that, as we've said before, it's really an exciting time to practice in the migraine world because
Right.
now we have other options for our patients.
Right.
And with these particular classes of medicines, what I think is the best part is that these are specific for migraine. All the other
Absolutely.
medicines that we have, even though we have great evidence, we've borrowed them from other disorders.
That's a
So
really good
these
point.
really are migraine specific, which is terrific.
Right. And having the
Terrific.
option of another route.
Yes.
So giving it nasally, again, if you've got a patient who has a lot of nausea and vomiting, they may throw that pill up and they don't know if it's
Hmm.
worked or not. If you use a nasal spray, you don't have to worry about if it's gotten into your system or not. So, Maureen,
Right.
I wanted to ask you a little bit about when patients start going into that medication overuse. We didn't really cover episodic to chronic
Yeah.
preventative treatments. What would make you start to use that preventative sooner? Could you explain a little bit about episodic versus chronic and where we would place those preventative medications?
Sure. So when we look at definitions of episodic and chronic migraine, episodic migraine are people who have headaches less than 15 days a month. And those who have headache 15 or more days, the headache is considered chronic. And it has to be that way for the previous 3 months. So they have to have a track record with that frequency. You can drill down a little further and you can look at episodic migraine in low frequency episodic, which means that people have up to about, maybe 7 days a month with migraine. And then high frequency episodic are those people that are like from that 7 or 8 up to 14. And as they're keeping their headache calendars, you can see this happen if they're overusing an acute medicine. They'll start to tick up on the number of headaches that they're having each week. And then as you calculate it up, they're ticking up on the number of headaches that they have each month. And we talked a little bit earlier about, when to try prevention. But even if we have somebody on, say, one of the standard preventive therapies, maybe they've done super well with, say, an anticonvulsant, anti-epileptic for a long time. And then you look at their calendar and you're like, oh, no longer are they having 4 attacks a month, now they're having 8. That's a time to really look at perhaps some of these novel therapies to see if there'd be a place for that treatment with that individual.
Right. Or possibly adding something on to that, maybe a second, even if it isn't one of the new novel therapies, adding on either a non-pharmacological treatment or having to add a second other preventative treatment as well.
And one of the things I think that we can kind of use to our advantage with labeling something episodic or chronic, the monoclonal antibodies are approved for chronic migraine, and so is onabotulinum toxin A. So if we have somebody with chronic migraine and we're working with, say, a third-party payer, we may be able to get that medication approved based on that diagnosis.
Right. So breaking that down to those important points is helpful. And the other thing, too, to look at when we're looking at the chronic migraine patient, those patients have the higher presenteeism. So they're maybe at work, but they're not able to do their job as well. They're higher absenteeism, lower wage earning. They may lose their jobs because of the amount of migraines they have. So even though it's only about 6% of the population, they are truly the ones that are struggling. And we look at some other populations, the post-traumatic headache population, especially in the veteran population, it may be as high as 20% that have the chronic migraine. So looking at multiple ways to reduce that can be extremely helpful. Well, Maureen, you've mentioned migraine diaries a couple of times, and it's always a struggle to ask patients to do. It's so helpful, and there's multiple ways to get a migraine diary. You can use a paper copy, or there's several electronic apps out there for the iPhones and the Android phones. However, getting the patient to do that, what are your secrets to getting that done?
Well, I think it's hard because some people will say to me, I don't want to write it down. It just makes me feel worse. It makes me focus on the pain. But I really try to explain to them from the very first visit that this is a partnership, and that by recording this and really identifying what their triggers are and how their acute medicine is working and how their preventive medicine is helping can really help to inform what we do next in terms of treatment. So I really try to keep it simple. I have them just record, even with symbols, the intensity of the pain, the frequency, and the duration. And if they choose, they can put triggers in if they like. I like them to record their acute therapy, and I like them to keep track of exactly what they're taking in terms of prevention on the calendar as well. But we use it. That's the other thing. When they come into their visit, a lot of times that's the first thing that they'll hand to me, and they'll show me whether they're better or they're worse or not changed. And it's really, it's helpful because we all want to forget about pain. And so if you see somebody every 3 months, a lot of times they can't remember a headache that they had a month ago, but they'll focus on what's happened last week. So I really try to frame it that way for them. And I have relatively good success, but I still have my outliers who just say, nope, not going to write it down. So Karen, any tips that you have?
I kind of equate it to you taking your car to the mechanic and saying it, making a noise. I can't tell you where, I can't tell you how often. And sometimes that helps the patient understand the importance of it. I also let them know, as much as I want to be there to help them, I don't take this home. They take this home. And so it's up to them to be the ones to take part in that 50-50 partnership in order to understand what's going on. But again, like you said, making sure you look at that calendar if they fill that out, making sure that is part of so did you bring that calendar? And if they haven't brought the calendar, asking them what's keeping you from keeping the calendar. This is a really helpful way to know where we are with your treatments. It also helps them track what's working and not working so they can see the benefit of that. I remember years ago having a patient come in, and she was telling me she had maybe 4 headaches a month. And after I had her track it, we realized she was really having about 20. There were 4
Mm-hmm.
really severe ones, but there were many that were much milder and slowing her down. And so it was important for us to realize that. And one of the key questions that I ask patients now is how many days are headache free in order to get a more accurate count, because they may just tell you about their worst headache.
And they do. That's such a good way to frame that. To say to them, how many days are you absolutely clear? You have no pain whatsoever. And a lot of times they'll sit and reflect and they'll realize that they have something all the time, even if it's at a low
Right.
level.
Right. And how can they function with that?
Mm-hmm.
So I think, again, trying to figure out what works for that patient and what their goals are. Their goals can be totally different from mine. I can be like, hey, I want to get you down to just a couple of months, but they may say, I have this important event coming up and I need to be making sure that I have treatment right then and there and that this is not going to interfere. Everybody's goals are different. They may have different family things going on that we aren't aware of. And so finding out what socially is affecting them, what their lifestyle is like, who's in their home, all of those different things play into not only what their goals are, but what treatments may be most important for them versus others that if you need to use a neuromodulation device, you need time every day to sit down for that
Mm-hmm.
20 minutes or so to use that. If you're a busy mom who's also going to school or going to work, you may just not have that time. So having those frank conversations with them is extremely important.
Absolutely. Well, thank you, Karen. We've had a great conversation on migraine prevention today. And as a reminder, don't forget to claim your CME CE credit at pce.is/migraine. Thank you so much for listening.